Hello, I'm Elizabeth Ford, the Office Manager for Spinal Diagnostics, and I want to welcome you to the presentation and education webinar presented by Dr. Robert Hiros, sponsored by Spinal Diagnostics. Just want to take a moment to thank you for joining us today, and I hope you enjoyed the agenda. If you open to full screen mode, you'll be able to see Dr. Hiros and the presentation. Dr. Hiros, take it away.
Thanks, Liz. I just want to kind of echo what Liz just said and welcome you all here. I'm very glad that you're able to watch this, and hopefully it will be educational for you. So I'm Dr. Hiros. I'm one of the co-owners of Spinal Diagnostics. We're an interventional and conservative pain clinic here in Tualatin, Oregon. And we have a great team of providers here, myself and my partner, Dr. Anderson, who are both owners of the practice. And then we have two mid-level practitioners, Deborah and Tyler. And I do just want to say a quick, something about that. I know that everyone wants to see the doctor, not the mid-level. I get that, and I would be the same way. But the reason we have them here is because they're excellent, and we have trained them ourselves personally, and they let you get in the door faster, and they get you to us faster. If we did not have Deborah and Tyler, you would probably be waiting 6 or 8 weeks just to see Dr. Anderson or myself, and then having to wait longer after that to have something done about your pain. So while we do understand those concerns, rest assured you're in good hands with Tyler and Deborah if you do end up seeing them, and that will just get you to us even quicker. So for tonight, we just want to talk about a few different things. I want to talk about pain as a general issue in the United States right now today, the different kinds of pains and what we do for different treatment options for the most common of these. Want to focus a little bit on just why narcotics aren't a good long-term option for pain, and then talk about some newer innovations and future options for us. So pain is a big issue in this country, to put it mildly, and you're not alone if you have it. Over 100 million people in the US suffer with chronic pain. It's one of the most common reasons why people come and see the doctor. It's associated with all sorts of nasty stuff like depression and anxiety and reduced mobility and reduced quality of life. It actually affects more people than heart disease, cancer, and diabetes combined, which is amazing. And finally, it costs the United States over half a trillion dollars annually in healthcare costs. And that's everything from the actual cost of getting a surgery or procedure or going to physical therapy or a prescription, but also not being able to work and provide for your family. So what is pain? Kind of start with the real basics here. Pain is a normal, healthy thing at times. It's the body's natural way of telling you that your body's in danger and that possible damage is occurring. So when you put your hand on a stove, pain is a very good thing because it's telling you to get your hand off that stove real quick. So pain signals can be released from injury, from illness, from chemical changes within your body. And basically, wherever the pain starts, it sends a signal that goes through your nerves that end up in your spinal cord. And then those nerves or those signals go up the spinal cord to your brain where it's kind of processed. Now, by definition, we kind of traditionally break pain down into acute or chronic pain, which is either less or more than 3 months duration. We can break down pain in other ways too. We talk about regular pain, which is also, we just call that pain from skin or soft tissue, muscles, joints, internal organs. And we really differentiate that from neuropathic pain, which is damage from or to the nerves or the nervous system itself. So it's really an entirely different beast. Finally, there's something we call psychogenic pain. And what that means is not the pain is in your head. It just means that there's a connection between what's going on in the brain and the body. It's also can be looked at as the difference between pain and suffering, or the mind-body connection. And those are important things, especially with chronic pain. So we also use the term mechanical pain. Now, mechanical back pain is something where there's pain from physical stress on the spine itself. So any kind of pressure or distress on the spinal column, the bones, the muscles, the joints, the discs, that kind of thing. Mechanical pain is the type of pain that kind of gets better or worse depending on what you do. So there might be certain positions or activities that are perfectly comfortable, but others that are not. So pain that is off and on or intermittent, that is kind of what we mean by mechanical pain. And that's really to be differentiated from neuropathic pain. So neuropathic, or the nerve pain, lasts a lot longer than you would expect for whatever it was that caused the pain, whether that's a disease, an injury, or a surgery. Neuropathic pain is typically constant. It's there 24/7. It's inescapable no matter what you do. Now, it may get better or worse depending on certain things, but it's always there. So pain that is constant. Now, chronic neuropathic pain has several factors or things that are kind of classic for it. And when a patient talks about pain that's electrical or burning with numbness and tingling, on fire, pinching, hot or cold, these are all terms that make us as doctors think about nerve pain. Another way of looking at pain is rating it. So there's lots of different ways of measuring pain, none of which frankly are very good, but they're what we have. So on the left there, you see that kind of the classic 0 to 10 pain scale. You can also look at it with smiley faces or different descriptors. On the right-hand side, you see a pretty good chart that has descriptors of everything from unable to move, 10 pain, to no pain at all, 0. It's important to recognize that pain is subjective. So what I call a 10, my wife probably calls a 3 because she's a lot tougher than I am. But what I typically tell people for a 10, it's whatever the worst pain that you've ever had in your entire life. For many women, that's childbirth. Maybe not, though. Whatever the worst pain that you've ever had in your entire life, that's probably what your 10 is. Now, chronic pain conditions of interest. So the types of things that we see day to day here at Spinal Diagnostics that cause pain. So failed back surgery syndrome is a very common one, and that just means somebody who's had back surgery before, but unfortunately either developed pain again or it never went away to begin with the surgery. Sciatica, which is just a fancy medical term for shooting pain down the legs that comes from the back. You can have pain from the spinal joints, any one of them, pain from the spinal discs, any one of them. You can have headaches that are associated with neck pain. You can have peripheral neuropathy or some type of damage to the nerves out in the extremities. Something called complex regional pain syndrome, which I hope you never, ever, ever, ever have to live with yourself. People who have amputations often still have pain from the limb that was amputated or just the residual limb. We have spinal stenosis, pelvic pain, any kind of post-surgical pain. These are the types of things that we see day to day. I do want to say a few words about MRIs. Quick question, which of these cars runs better? Now, it's very tempting to say, obviously, the one on the right runs better than the one on the left. But the point I like to make is that you can't tell that by looking at the picture. For all we know, that car on the left runs very well, and the car on the right is a lemon. You can't tell that strictly by looking at the picture, and that's what an MRI is. It's a picture. So critical take-home point, honestly, if you don't really remember anything from today's webinar except this would be a good thing. So not all findings on an MRI cause pain. Another way of saying that is you can't see pain. Pain is invisible. Pain does not show up on pictures like x-rays or CT scans or MRIs. We also know from studies that most adults who don't have any back pain have abnormal MRIs if they bothered to look. And that could be bulging discs, pinched nerves, arthritic joints, narrowing of the spinal canal. Lots of yucky stuff shows up on people who don't have pain. It's hard to know why, but because of this, we know that just because there's a bulging disc or a pinched nerve or whatever, just because it shows up on the MRI does not necessarily mean that it's causing pain or causing your pain. So let's kind of go into a little bit more depth on some of these more common issues that we see day to day. So sciatica, which we also call lumbar radiculopathy. Again, it just means pain, numbness, weakness in the leg that radiates down from the back into the buttocks and then into the leg itself. So sciatica is not a very specific term because the sciatic nerve is actually made up of lots of different nerves that come out of the lower back. Most of the time when it's sciatic pain, it's usually from L4, L5, or S1, however. Those are the bottom 3 levels. Sciatica is very commonly caused by a bulging disc or a pinched nerve. Now, other things can pinch a nerve too, like a bone spur, but it's commonly done by a bulging disc. And people typically call this the same kind of terms that we mentioned with neuropathic pain because this is pain coming from a nerve itself. So this is shooting, radiating, electrical, burning, my leg's on fire, that kind of thing. And then on the lower right-hand area of the screen, you can see an MRI. And this is kind of a a vertical slice. So the arrow is pointing at the big bulging disc there between L5 and S1. Spinal stenosis is another very common cause of back pain and disability. Spinal stenosis just means narrowing of the spinal canal. Now, there's two areas, and I apologize because I'm not sure if you can see my cursor here, but in the middle of this screen, you can see the circle here with all these little dots in it. Those are the spinal nerves. And to the left and right, there's kind of a white opening. Now, that's the opening where the big nerve comes out. So that's called the foramen. And narrowing of that can be considered spinal stenosis, or narrowing of just the whole big circular area in the middle of the spinal canal. That's kind of the traditional thing we call spinal stenosis. Now, lots of things can cause narrowing, but most common is just degenerative change with age. Now, spinal stenosis is one of those things that can show up on an MRI in somebody who doesn't have symptoms. So it's always important to kind of ask these questions and figure out, does the MRI match up with the kind of pain somebody's having? So the classic symptoms for spinal stenosis are back pain or leg heaviness that makes it difficult to walk, but it goes away almost immediately when you sit down. Another classic hallmark of this is that if you lean on a shopping cart, it seems to help. And that's just because if there's a very, very tight, narrow area of the spinal canal and you lean forward, it kind of opens it up a little bit. Now, there's a lot of different things you can do for it, but traditionally, the kind of curative solution for this is surgery. Now, however, we do have, and thankfully, we do have some newer, less invasive, less risky stuff that I'll mention down the road here. Now, mechanical pain we talked about earlier, so there's lots of mechanical pain syndromes. The first most common thing is probably pain from the joints of the spine, which are called facet joints or facet joints. Facet joint pain is often worse when you arch your back or extension, or even rotating. So rotational motion can make this pain worse as well. And facet pain, especially in the neck, is often caused after a whiplash injury or hyperextension injury. So getting rear-ended in a car accident is a very common cause of this. Another thing that can cause pain are the discs or the shock absorbers in the spinal column. That kind of pain is different. It tends to be worse when you're sitting down or driving or bending forwards as compared to going backwards. Another very common area of pain is from the sacroiliac joints, which causes kind of gluteal pain or buttock pain. But it can mimic sciatica. Sometimes it does seem to shoot into the thigh a little bit. Peripheral neuropathies are a very common cause of nerve pain. Peripheral neuropathy just means that it's nerve damage outside of the spine itself. Now, the most common cause, question mark, because we don't know. The most common cause is idiopathic, which is another fancy word for we don't know what it is or what caused it. But it can result from trauma, infection, any type of metabolic disease or exposure to toxins, and it can just be genetic as well. So diabetic neuropathy is a very common one. Alcohol-induced neuropathy is another common one. And neuropathy most often affects the feet or the foot and ankle, and it's described kind of in similar ways, again, to the nerve pain in general: stabbing, burning, tingly pain. A lot of times patients have peripheral neuropathy that's bothersome, but it's not necessarily painful. So it's possible to have these conditions just with numbness or tingling, not with a lot of pain. I mentioned complex regional pain syndrome earlier, and I specifically mentioned it as something that you really don't ever want. This is a rare and chronic pain condition that most often affects a single limb, be it an arm or a leg or the hand or the foot or an elbow. It is usually, but not always, after an identifiable or a known injury. Now, that can be something as innocuous as just a sprained ankle or something as obvious as an amputation. Now, complex regional pain syndrome, or CRPS as we call it, is believed to be caused by damage to or malfunction of the outer or the peripheral nerves, but also with the central nervous system and how they communicate with each other. Something's gone wrong there. It's characterized by severe chronic pain that is very out of proportion to what you would expect for whatever it was that happened, whether that be the amputation or a sprained ankle for that matter. It's characterized by the skin being very sensitive to touch, where if it's the foot, for example, inability to even wear a sock or have a sheet on it. The skin can change color. It can get blue or mottled or purple or red. The extremity can swell up and down on its own. It can feel hot or cold. Sometimes it even sweats differently than the other extremities. Now, treatments for chronic spine pain, changing gears here a little bit. There's a lot of different ways of looking at the different things that we have to offer, but one way is to kind of break it into some tiers. And traditionally, the first tier, most conservative treatments are what you're going to start with, and that's just going to be time and rest and ice and physical therapy and stretching. Other modalities such as acupuncture, chiropractic, or massage. Sometimes even cognitive or behavioral therapy, learning ways to kind of manage pain, sort of mind over matter. Over-the-counter medications, aspirin, Tylenol, anti-inflammatories, electrical stimulation, biofeedback, all of these are very conservative, good first-line therapies. Now, when those fail, we move up into the second tier. Now, that's maybe low-dose prescription pain medication or other medications that are specifically made for nerve pain, but also spinal injections. So a lot of the stuff that we do here on a day-to-day basis is second tier, and hopefully that takes care of it. But if not, we end up in the third tier. And again, traditionally, those options are, unfortunately, surgery, maybe something like a spinal cord stimulator, which I'll talk about later. But really, from a concerning standpoint, especially in this country lately, is long-term narcotic or opiate medication use. Now, understanding the risks of narcotics is important. I think everyone knows right now in 2020, doctors don't like to prescribe pain medications as much as they used to. And there's a bunch of reasons for that. It's not because we want you to suffer or that we don't think that they have a role, but it's just understanding what the role is and what the risks are. So narcotic medication is basically made for short-term pain. That's what they were designed for and made for, and that's what they're good at. So for patients who have very significant short-term pain, maybe a week or a couple weeks after an injury or a surgery, short-term modest use of narcotic pain medication is totally appropriate and reasonable. The problem is that we got into a situation where doctors started prescribing them for long periods of time for chronic pain. And there is no study, there's literally not a single piece of research out there that demonstrates that long-term opiate use is good for chronic pain. And yet we use them, and that's not a good thing. And that's because of the risks. There's risks of overdose, death, addiction, cognitive issues, balance issues. You develop tolerance over time, which means it takes more and more of the medication to do the job. They can cause nausea and constipation. So there's a lot of reasons why we don't like them. The one I keep circling back to is they're not really made for or good for chronic pain. So non-narcotic medications often are actually better, which can be counterintuitive. There's steroids. Steroids are the most powerful anti-inflammatory medications we have, so much so that by definition, all other anti-inflammatory medications are known as non-steroid or non-steroidal anti-inflammatory drugs, NSAIDs. Those are the things over the counter like ibuprofen, Motrin, Aleve, and then prescription strength ones like Celebrex. Tylenol or acetaminophen is not an anti-inflammatory, but it's an over-the-counter pain medication. There's lots of antidepressants that actually have good data, good research that show that they do help somewhat with chronic pain. There's older ones like amitriptyline or nortriptyline, but newer ones like Cymbalta as well. Then there's this special class of medication for nerve pain. They're mostly anticonvulsants, which means they're actually seizure medicines, but two of these in particular, one called gabapentin and one called Lyrica, are both very good with nerve pain. So why we even use these? Well, it's because if they're anti-inflammatory, they can reduce swelling and inflammation. All of these can reduce pain. They allow patients to tolerate and participate in conservative treatment like physical therapy better. They can improve our ability to function at home and work, and it helps us to avoid the more dangerous and invasive options. Now, when we talk about invasive options, in the same way that we like to try the tier 1 stuff first, we like to try, invasive options like injections before something like surgery. So common interventional procedures that we do are epidural steroid injections, diagnostic blocks or facet injections, sacroiliac injection, and radiofrequency ablation. Now, all of these are different and they all have different roles and different goals. So it's important to understand these, and that's really our job, and it's also our job to explain to you why we're recommending a specific procedure. But really, one of the big things we look at is a certain procedure going to be diagnostic or therapeutic or both? An epidural steroid injection is probably the most common procedure that Dr. Anderson and I do. This is for nerve pain. It's where the needle kind of goes in from the side. And again, I'm not sure if you can see my pointer here, but it goes into the foramen, or the opening where the big nerve comes out. And on the other side, on the right-hand side, you see an X-ray from an actual procedure. And the little long straight line, or the line that's more horizontal and thin, is the needle. And then there's a much darker line kind of going towards the spine, and that's the actual nerve that's coming out there. Facet joint injection on the left-hand side is where we inject into the joint itself. And then a radiofrequency ablation on the right-hand side is where we cauterize the little nerves that go into a joint, and that can help with pain long-term. The sacroiliac joint can be injected and can be very helpful for that type of pain, and if it helps, it's partially diagnostic. All of that is done to try and avoid spine surgery. That is really kind of the number one goal, aside from getting you back to doing the things that you want to do, getting you back to your family and to your job. We really want to avoid surgery. There are times when surgery is unavoidable, okay? And that's okay. Spine surgery is indicated and appropriate when there are objective findings like weakness, an ankle being weak and not being able to lift up your foot is called foot drop, or there's bowel or bladder issues due to a compression of the spinal canal or the spinal cord or the nerves, or when there are mechanical issues with a very clear cause, a very clear target, and everything else has failed. Now, spinal surgery is most likely to go well when those are all true, when there are objective findings. It's also most likely to help for leg pain more so than back pain. So if you have back pain and leg pain and you end up having surgery, it's probably more likely that it's going to help the leg pain. It certainly can help both. When it becomes back pain only with no leg pain, then you really have to think long and hard about back surgery. It also is most likely to help when there are very clear MRI findings which clearly explain the problem. Going back to what I said about MRIs earlier, just because there's a bulging disc and you have back pain does not mean that fixing the bulging disc is going to fix your back pain. I wish it were that easy. Spine surgery is not likely to go well when back pain is the only issue, as I mentioned, when conservative treatment has not been exhausted, when you've already had back surgery before. It's kind of a law of diminishing returns here. If you've had one, a little less likely the second's going to help, and if you've had two, so on and so forth. What I always tell people is if you don't want to be that guy who's had 6 back surgeries, don't ever get the first one if you can avoid it. And it's also not likely to go well if the patient is focused on a fix or a cure, because a lot of times it's not. So what makes somebody a good candidate for elective spine surgery when all the following are true? There's clear pathology on the imaging study like an MRI that surgery can address. The pathology matches up with or explains the actual symptoms or pain. Conservative treatment has been tried and failed. A surgeon offers surgery and the patient desires surgery. Number 5 there sounds kind of silly, but in my mind, the number one contraindication to surgery, in other words, the number one thing that makes surgery not a good idea, is that the patient doesn't want it. So sometimes there is pathology, and the pathology does match up with the symptoms, and conservative treatment has been tried and failed, and the surgeon wants to operate, and the patient doesn't. And you know what? Surgery is not a good idea, not liable to go well. So let's say you're sitting there thinking, well, I've done physical therapy, I've taken all these different medications, I've had injections, I have no quality of life because I've got this chronic pain, especially chronic nerve pain. I either don't want surgery or I'm not a candidate for surgery for whatever reason. What else is there? We do have other options these days, which is a good thing. And neurostimulation therapy is one of the best ones, really. So this is a non-opiate alternative for chronic neuropathic pain conditions. And basically what this is it uses electrical stimulation to help block pain. So I call a stimulator a pacemaker for pain. It's actually very similar technologically to a pacemaker. A big benefit of neurostimulation is that you get to try it. So you do a 1-week low-risk temporary trial to find out if it's going to help. There's actually very good evidence for this. There's good research behind it, and there's lots of new options emerging and on the horizon. So it's not perfect. Nothing is, all right? So we have to be honest and look at the pros and the cons. So neurostimulation is not a cure or a fix for anything. It's just a very fancy high-tech therapy. There's no long-term guarantees, so it's certainly possible that somebody does well initially, but for whatever reason, long-term doesn't. It doesn't prevent anything from happening, so just because you have a stimulator put in doesn't mean that you still can't get degeneration or get in an accident and hurt yourself. These things run on electricity, which means there has to be a battery, and the battery does have to be replaced. Depending on the device, some of these need charging, some of them do not. It's an implanted medical device, so that's not something to get into lightly. They do impact the type of MRIs you can have in the future once you have one of these. Now, for the most part, you can still get MRIs. There's just a little, a couple of hoops you got to jump through here and there. A stimulator is also not a kind of, put it in and forget it type of therapy. It's really a commitment between the doctor and the patient, and it's an ongoing relationship, and it requires the patient to be educated and cooperative and part of the healthcare team. Now, on the other hand, the good stuff about it, a stimulator is not a narcotic. It's not steroids. Steroids aren't good for you either. Compared to traditional back surgery, it's much less invasive, it's much lower risk, has a much easier recovery, and it's a lot less expensive. Now, I consider a stimulator more than anything just a quality of life device. And when the other things aren't good options, quality of life becomes a pretty good goal. And it could realistically improve quality of life by 60 to 80%. I don't think that expecting a device like this to help 100% is realistic, especially when you've had other things in your past like spine surgery. So 100% pain relief, not realistic. 60 to 80%, I think that's pretty realistic. It does offer that benefit of a trial period, and the trial period itself is very low risk. It's minimally invasive. It's just done through a small needle with no surgery at all. It takes about 20 minutes. It's done under very light sedation, not general anesthesia. You're out of there in about 2 hours total. It's fully reversible, which means at the end of the trial, those little electrodes or wires just come out, and it's commitment free. So regardless of how much benefit you get or you don't get during a trial, you don't have to do it if you don't want to. Now, neurostimulation for chronic pain basically works like this. We know that the pain signals travel up the spinal cord to your brain where they're processed. So with a stimulator, you have a generator, which is the battery, and that's that gray thing you see down in the lower left between the number 2 and 3 there. That's a temporary generator, but it's the same concept. That's the battery. That's the computer. It sends these electrical pulses up the wires, and those electrical pulses hopefully block or reduce or inhibit the pain signals in the spinal cord. Sometimes you feel a more pleasant sensation from the stimulator, but most of the time nowadays, you don't feel anything at all. So again, reasonable goals is something I've kind of harped on a bunch. So, 50 or 60 to 80% pain relief, improved function, improved ability to do daily activities like walking or standing or sitting or sleeping, or just around the house stuff. It's reasonable to hope that it might help you reduce or maybe even eliminate the need for pain medication. And it's reasonable to hope that it could provide a long-term option for persistent nerve pain. So who's a good candidate for this? Pain is nerve, it's neuropathic. Stimulators are not made for the mechanical type of pain. Knee pain just is from a knee joint that needs replacing, from arthritis. That's not the kind of pain we typically treat with this. It's neuropathic, and it's been present for more than 6 months. It's persistent, inescapable, 24/7, constant pain. It's there, plus or minus always. It doesn't go away when you sit down or lay down. It's there all the time. You've tried and failed conservative therapy, and you're not a good surgical candidate. And again, I should also say that this is not for mild pain. So this is for significant pain that is having a significant impact on quality of life. Some of the things that lead us to consider this as a therapy for somebody: failed back surgery syndrome, chronic sciatica or chronic nerve pain, the complex regional pain syndrome I talked about earlier, that's definitely an indication for this, peripheral neuropathy, chronic pelvic pain. There are some conditions that are amenable to treatment with a stimulator. And then any kind of persistent nerve pain following a surgery, like a hernia or a knee surgery, can leave you with pain, or hip surgery. Even a vasectomy or pelvic floor therapy or surgery can cause this. So there are actually lots of indications for this. Thankfully, for the most part, there's very good insurance coverage for neurostimulation therapy when it is appropriate. It's important to remember. It's also important to know that this therapy, like most other therapies, has evolved over time and continues to evolve. So it's not the same as it was 20 years ago. Newer technologies are better tolerated and more effective. In the past, maybe even as recently as 6 to 8 years ago, when you had a stimulator, you felt it. Anytime it was turned on, you felt this buzzing sensation in the back and the waist and your hips and in your legs. A lot of people didn't like it. That pretty much is gone now. There's lots of high-tech options. Some of these options are upgradable without surgery, so they can upgrade a device just with computer software wirelessly. Batteries last longer than ever. That's something that's always on the forefront of our mind as physicians, is how do we make these batteries last longer? Because when you do have to replace a battery, it's a surgery. It's a minor surgery, but it is a surgery. So we want that battery to last as long as possible. And nowadays, lasting 5, 8, 10 years is not unrealistic. There's lots of ongoing research about this. And that's something that's close to my heart and near and dear to my heart, is that I am actively involved in clinical research. So we're always trying to find ways to make the therapy better, to help more people, to keep it safer and improve our outcomes. So, at Spinal Diagnostics, we're committed to the future of pain management. So this is a paper that I was a co-author on that was published in a journal recently. We're working on lots of other things, and I'll just throw a little mention here to a new study that we're working on. So if you're out there and you have severe back pain, more than you have leg pain, if it significantly impacts your quality of life, and if you've been told you're not a candidate for back surgery and you've never had back surgery, you might be a good candidate for this study. So give us a holler. Our commitment and our goals at Spinal Diagnostics are to get you in a timely manner. And that goes back to what I said at the very, very beginning. That's part of the reason why we have our mid-level practitioners. We don't want you having to wait 2 months to get in the door to see us. We are committed to trying to provide education in the ways that you can understand. And that's really just trying to explain things in maybe in non-medical terminology to make it easier to understand, and our willingness to take the time to do that. We're committed to trying to raise awareness in the community, which means patients and doctors, about the non-opiate options for chronic pain. We are willing and able, and all the time are fighting with insurance companies when they put up obstacles, which they always do. But we will take the time to fight with them on your behalf so that you can get the treatment you need. We are committed to excellent communication, not only with you, but with your physicians, your other physicians who may have referred you to see us. We're open to feedback. We want your feedback. We are not afraid of constructive criticism. So if you have a good experience with us, we'd love to hear it. If you don't have a good experience, we want to hear that too, because that's how we get better. And as the owner, as the co-owner of the business, that's very important to me. We are always trying to surround ourselves with talented and committed professionals who are going to help you the best they can. And it's sad that this needs saying in this day and age, but ethics are very, very important to us. If we recommend a specific therapy, option, procedure, device, we want you to understand that it's because we think it's the right thing for you and for no other reason. And that is a commitment of ours. So thank you for attending. Thank you for watching. I'm very appreciative of the time you spent doing this. Right now in late 2020, I think we've all had a pretty unique year, and we're always looking for ways that we can engage with you, our patients, past, present, and future. So we're hopefully going to do more of these webinars. I know my partner, Dr. Anderson, has done one that many of you have probably already seen, but stay tuned. There's more to come. We look forward to treating you. And as always, please reach out if you need us. Thank you so much.
Thank you so much for joining this educational event. I hope you all feel more educated about your options to alleviate your pain. Please feel free to call our office if you have any questions or if you'd like to schedule a consultation with Dr. Heroes or any of our other providers. Contact number is 503-885-1515. We're open 8:30 to 5. You can always request an appointment online at our website at spinaldx.com. Again, thank you for joining us, and you all stay safe.